Welcome back, future doctors. Today's topic is acute acalculous cholecystitis, an important but often overlooked cause of acute abdomen. This condition accounts for about 5 to 10% of all cholecystectomies. Unlike calculous cholecystitis, it is more fulminant and often presents with gangrene, perforation, or empyema. It typically occurs in critically ill patients. Risk factors include sepsis, ICU stay, total parenteral nutrition, major trauma, burns, diabetes, prolonged fasting, immunosuppression, mechanical ventilation, cardiac surgery, childbirth, AIDS, and systemic vasculitis. It is most common in elderly men. The presentation is often insidious. Up to 75% of patients lack classical right upper quadrant pain. Instead, they may present with fever, sepsis, hyperamylasemia, or unexplained clinical deterioration. By the time of diagnosis, half already have complications like perforation, abscess, or gangrene. On labs, there's leukocytosis with left shift and liver enzymes may be abnormal. Hyperamylasemia is also common. For imaging, ultrasound may show gallbladder wall thickening and pericholecystic fluid, but has high false negatives. CT scan is superior, showing wall thickening, pericholecystic fluid, or even intramural gas. The most sensitive test is a HIDA scan, where the gallbladder fails to opacify. But remember, false positives are possible, especially in severe liver disease or prolonged fasting. Differentials include calculous cholecystitis, acute pancreatitis, peptic ulcer disease, pyelonephritis, and hepatic abscess. Management begins with broad-spectrum IV antibiotics and supportive care. Definitive treatment is cholecystectomy, open or laparoscopic. If perforation is suspected, open surgery is preferred. In critically ill patients, ultrasound-guided percutaneous cholecystostomy is the first choice, with a success rate of about 90%. Endoscopic transpapillary drainage may be considered if percutaneous drainage isn't possible. Mortality is less than 10% in community-acquired cases, but in critically ill ICU patients, it can reach up to 90%, making early recognition crucial. So the exam pearls. Think of acute acalculous cholecystitis in a critically ill elderly male with sepsis, no gallstones, and unexplained RUQ findings. Best imaging is CT. Best confirmatory test is HIDA, and treatment is early drainage or cholecystectomy. If you found it useful, don't forget to hit the like button, share it with your friends, and subscribe to the channel for more high-yield medical content. See you in the next video.